So, good evening, everyone. Am I audible, Abinya?
Yes.
Okay. So, a very warm welcome to the second day of our patient management workshop organized by Stethify, the official podcast of IMA MSN UP. On occasion of World Hepatitis Day, we have brought for you this 5-day event wherein we will discuss various aspects of patient care and management with various eminent faculties from across UP. On the first day, we had with us Dr. Shiv Joshi, National Convener, IMA-JDN, who threw light on the bioethical aspects in clinics. Before we proceed, I would like to thank Dr. Rajneesh Raj sir, Convener, IMA MSN UP, Dr. Rahul Anand sir, General Secretary, IMA MSN UP, and the entire organizing team of Stetify for organizing this wonderful event. We also have guests from the national team with us. I would now hand over to Dr. Rajneesh Raj sir, who would introduce these guests to us. Sir, over to you now.
Thanks, Ashwath. On behalf of IMS and UP State, I would like to welcome our guest of today's event and our national co-conveners of IMS, Meet Gonia and Shreya Namjoshi. I would like to state that Meet and Shreya are two of the persons which our whole team admires the most for their working pattern and efficiency, and the support which they have always showered to our state team. It's all has been possible because of our brilliant national team support with us. Now I request Meet and Shreya for some motivational words for the team. What do you mean, Shreya?
Thank you very much, Rajneesh bhai. Firstly, I thank all of the team to organize this. Sir, welcome Ravi, Kant, Tiwari sir, Saswat and Abhinya and all the team, Harsh, Rai and Sneh, Sahani. You guys are wonderful, and I am seeing from last 2 to 3 months, UPMSN is working very hard, and I believe that Rajneesh bhai and Anand bhai is the one who okay. So all the best team, and over to you, Shreya.
Thank you, Meet. Greetings to Dr. Ravi Tiwari sir, who's with us today. And I just like to congratulate Team IMMS in UP for organizing this wonderful event, and especially Dr. Rajneesh, because he has been amazing. For the national team as well as for Team MS in UP, and he's been always motivating everyone. So congratulations, and I hope you guys continue organizing such wonderful events. Thank you.
Thanks, Meet and Shreya. Shashwat, over to you.
Thank you, sir. I welcome both the national guests with today. Moving on to today's event now. We will discuss in details how to write a good prescription for hepatitis and prescribing the laboratory test for the same. And for this, please welcome our guest for today, Dr. Ravikant Tiwari sir. Dr. Ravikant sir is MD in Pharmacology and Therapeutics from Sarojini Naidu Medical College, Agra. Sir is currently working as an associate professor in the Department of Pharmacology in Heritage Institute of Medical Sciences, Varanasi. Sir has attended and presented posters and papers at various national and international conferences. He is actively involved in teaching and training of medical students. Sir is also the author of a book, Understanding Experimental Pharmacology. This book was the bestseller among the experimental pharmacology titles in the first year of its release in 2019 by CBS Publishers and Distributors, New Delhi. This book is particularly useful for MD pharmacology students, B Pharma, M Pharma, and MBBS students. Currently, Dr. Ravikant sir is also working on the manuscript of 2 more books in pharmacology. We welcome you from the bottom of our hearts, sir, and thank you so much for joining us.
So first of all, I would like to thank all of you and inviting me for this grand occasion of IMA MSN, and I would like to congratulate all of you and thank all of you, because I remember when I was a student at undergraduate level, there were no such events of joining together and having a talk on such important topics. This I can say is the change after the internet and such web revolution, that this has made all over of the country, the students can unite and they can discuss and they can share the important topics relevant to the medical students. I have seen your last videos also, especially on YouTube, and I have seen that you have talked with eminent persons in their field, for example, Naresh Jain sir and Milka Singh. So I think that this IMA MSN is reaching beyond the normal. They have reached to sky. I think in one word, they have reached to sky. And I would like to say that you should continue this journey not only through your MBBS curriculum, but beyond that also in your postgraduate, because this is a platform where most of the students, especially the first year students, second year and third year students and final year students, they can learn about most of the topics and discussions which they seem that in their classes some short discussion or some confusing is there, but you can solve their problem at this platform. So coming to the topic proper, thanks for the warm welcome first. The topic is hepatitis, writing a good prescription and prescribing the laboratory test. So today for this discussion, I have confined myself to the viral hepatitis only. And as you know that hepatitis is made up of two words, that is hepar and itis. Hepar means liver and itis means inflammation. So hepatitis can be autoimmune or viral hepatitis or alcoholic hepatitis or drug-induced hepatitis. Autoimmune hepatitis and alcoholic hepatitis, their prevalence has not much decreased so much in recent years, and drug-induced hepatitis also. But viral hepatitis, their prevalence has decreased worldwide, if you see the global prevalence, because of the universal immunization programs in various countries. So the important aspect in this is that if we follow the immunization schedule of the country, we can prevent the occurrence of such kind of infectious hepatitis. So I will focus on viral hepatitis only in this seminar or webinar. And I would like to request that you should further continue this topic or such topics in future also, because it is a very big topic. In fact, liver and hepatology is a very big topic. So it is not possible to conclude all the important aspects in a single lecture. So viral hepatitis consists of mainly 5 types of viruses: hepatitis A, B, C, D, and E. The important point is that hepatitis A and hepatitis E, they can cause outbreak, but usually, fortunately, they are self-limiting illness. But hepatitis B and hepatitis C, they can cause chronic illness. In fact, they can cause cirrhosis and hepatocellular carcinoma. So the severity point of view, from the severity point of view, hepatitis B and hepatitis C are more serious as compared to hepatitis A and E. So the topic for today is good prescription for hepatitis and laboratory investigations for hepatitis. So for any prescription, I would like to request all the students that once you become a doctor, you should prescribe by rational prescribing policy only. That is called good prescribing practices. And good prescribing involves it not involves a large number of drugs in the prescription writing or a large number of investigations in the prescription writing. It involves only the relevant and the drugs after making a provisional or important diagnosis. So for making any prescription or writing any prescription or writing any investigation, you should have a sound knowledge of that condition or disease in particular for which you are writing the prescription. So you must, I request all the students that you should go through the detail of the topics, especially such topics like medicine, pediatrics. These are the very important topics, and you should go in detail. So for investigations, you should know the which kind of virus consists of which, produces which type of immune response, primary immune response or secondary immune response, and which investigations are used for diagnosing those conditions. For example, if you see the hepatitis A, C, D, and E viruses, you can see that acute infection is characterized by production of IgM antibodies. And you have learned from your microbiology classes that primary immune response consists of IgM antibody response. While in the recovery phase, you can see that IgG antibodies are produced. That is the secondary immune response. So once you are writing investigations for hepatitis, infectious hepatitis, especially viral hepatitis, so to rule out which hepatitis virus is there, so you can write antibodies for a specific hepatitis A virus, C virus, D virus, E virus. So you can see that IgM antibodies are the screening methods of choice in acute infection. And in recovery phase, you can see IgG antibodies are there. In particular, SCV or hepatitis C virus, the RNA load is measured, SCV RNA titer is measured, and it helps to assess the condition and severity of the infection. Then hepatitis B has several type of markers. So I have made this slide separately. You can see that various tests for hepatitis B, for example, surface antigen HBsAg, envelope antigen HBeAg, antibodies like IgM anti-HBc, IgG anti-HBc, anti-HBs, anti-HBe, and hepatitis B virus DNA. All the hepatitis viruses are RNA viruses except hepatitis B virus, that is the DNA virus. In the similar way, you can see that in the slide that acute hepatitis B consists of IgM antibodies, anti-HBc antibodies, and surface antigen, HBs. Actually, HBs is the first marker to be positive in the hepatitis B infection. Then comes the IgM anti-HBc antibodies. Then there is a high level of hepatitis B virus DNA, that is the marker of hepatitis B infection. HBe antigen is the marker of infectivity and active replication. So it is positive in acute infection, but negative in the chronic hepatitis B virus infection. So we will discuss all these types of viral hepatitis one by one. The first, hepatitis A infection. As I told you that hepatitis A is the self-limiting illness. The incubation period is around one month, and it is transmitted by fecal oral route. Not only hepatitis A, hepatitis E virus also transmitted by the fecal oral route. So overcrowding, unhygienic conditions, poor personal hygiene, these are the risk factors or aggravating factors for this condition, hepatitis A as well as hepatitis E. But fortunately, this condition, hepatitis A, it is not converted to the chronic state. So it is a self-limiting illness. And vaccination is also available. Vaccine is available. And today I have focused the topic in the aspect of pharmacotherapy only. Vaccination and immunization I have not covered. So I will just mention that vaccine is present for this condition. The clinical presentation consists of before jaundice, before the development of jaundice, there is low-grade fever, anorexia, nausea and vomiting, fatigue, arthralgias, myalgias, headache, photophobia, cough, and coryza. So such initial symptoms, prodromal symptoms may be produced before the jaundice appears. And jaundice appears once the bilirubin level exceeds 2.5 milligram per dl. So the liver becomes enlarged and tender. This is called tender hepatomegaly, and the right upper quadrant pain and discomfort is associated. So lab diagnosis, if you remember the first two slides, and those are very important, that in the initial phase or acute infection, they consist of IgM antibodies, and in the later phase, so acute infection is characterized by IgM antibody for HAV. So you can write IgM antibody against HAV or HAV and IgM antibodies for the diagnosis. This is one investigation for the hepatitis A infection, acute infection. Then you can write bilirubin level, serum alanine aminotransferase. It is more than 10 times the upper limit of normal. Actually, all these investigations come in a one package that is called liver function test. So liver function test includes bilirubin levels, enzyme levels like ALT and AST, aspartate aminotransferases and alanine aminotransferase, and specific markers of infection of viral hepatitis. So yellowish discoloration of sclera, that is jaundice, and skin is seen when the bilirubin level exceeds 2.5 milligram per decil. So what is the management of hepatitis A? Treatment is symptomatic and supportive. No antiviral drug is given in hepatitis A because the disease or condition is self-limiting. No chronic state is seen. It recovers within a few weeks or few months. There is no role of antiviral drugs in this therapy of HIV infection. And case fatality is very, very low, about 0.1%. Then hepatitis B infection. Hepatitis B infection, as I told you, it is a double-stranded DNA virus, and incubation period varies from about 1 month to 6 months. If you compare the prevalence of hepatitis B infection from our countries to the Western countries, you can see that most of the hepatitis B infection, in contrast to hepatitis A infection, are bloodborne. They are transmitted by blood and other sources. So, as compared to Western countries, Indian and in these areas in which we live, vertical transmission, that is perinatal transmission, is more important, and this can cause the infection in the newborn or the early age children, as compared to Western world where sexual contact or percutaneous transmission is more important, and in those countries the infection is achieved at later age. But this hepatitis B infection, it has chances to develop into chronic hepatitis and subsequently cirrhosis and hepatocellular carcinoma. So this should be properly adopted in all the countries, that they should follow the universal immunization schedules to prevent the vertical transmission of from the mother to the baby. Because once the infection develops in the child, there are more chances to develop the chronic complications of the infection. For example, cirrhosis and the hepatocellular carcinoma, liver cancer. So if you compare the data between these two areas, the Western and Eastern countries, you can see that as the disease occurs later in the life, they have more chances, they have less chances to develop chronic complications. If the disease occurs early in the life, there are more chances of developing chronic complications like hepatocellular carcinoma and cirrhosis. The clinical presentation, it can also present like acute and chronic phases. In the acute phase, subclinical or anectic hepatitis, but it can progress to fulminant hepatitis. Extrahepatic manifestations can also occur both in acute and chronic infection. For example, serum sickness like features, or polyarteritis nodosa, or cryoglobulinemia, or glomerulonephritis. So acute hepatitis B, what is the difference between acute and chronic? So once the markers or the LFT, for example, ALT level, alanine aminotransferase level, it is persistently elevated for 6 months or more, it means that acute hepatitis has progressed to chronic hepatitis. So treatment of acute hepatitis B is mainly supportive, and appropriate measures should be taken to prevent infection in exposed contacts. And in this case also, immunization is very important, and particularly for the healthcare workers and medical students and medical professionals, because they are prone for needle injury or blood-borne infections. In acute hepatitis B, treatment is also supportive and symptomatic, but when to hospitalize the patients, those patients who have developed coagulopathy or deeply jaundiced or encephalopathy or significant comorbidities or cannot tolerate oral intake or poor social support system, so such cases should be hospitalized. And those hepatitis B cases acute hepatitis B cases which are having underlying cirrhosis, they should be considered for antiviral treatment, specific antiviral treatment for hepatitis B. Acute hepatitis can progress to chronic hepatitis, means once the markers of acute hepatitis, for example, enzymes and other markers are persistently elevated for more than 6 months, it means it has transferred to chronic form. And chronic form of liver disease can present as jaundice, splenomegaly, ascites, peripheral edema, upper GI bleeding, encephalopathy. These are the stigmata of the chronic liver disease. Once the patient develops hyperinsulinism, and it is characterized by decreased hemoglobin count, WBC count, platelet count, and increase in the prothrombin time, it means that there are chances of developing cirrhosis in that patient. So lab diagnosis of hepatitis B. As I have mentioned in the earlier slides, that various markers are available for diagnosing acute and chronic hepatitis B infection, particularly HBS, that is the surface antigen, and anti-HBC during the acute infection, and HBE antigen during the active replication or infectivity, to assess the infectivity of the infection. Now, assessment and staging of hepatitis B virus chronic infection. So once the infection is confirmed that it is hepatitis B infection, they should be gradually assessed during the follow-up also, because they tell about the severity of the disease as well as the progress of the disease. So they should be assessed. Number one, serological markers, then HBV DNA level, then liver severity of liver disease by liver enzymes, and non-invasive tests like a fibrosis scan or invasive test or liver biopsy if available. So assessing these investigations for follow-up period is also important. Now, selection of antiviral drug for chronic hepatitis B infection. Whom to treat and what drugs they should receive. So this PPT or this webinar or topic, this is based on the national guidelines of India, and that is from the National Health Mission on the treatment of hepatitis 2018. So according to them, all adults, adolescents, and children aged 12 years or older, antiviral therapy is indicated for chronic hepatitis B infection. And the nucleoside or nucleotide analogs, particularly tenofovir and entecavir, are recommended. Tenofovir is the nucleotide analog and entecavir is the nucleoside analog for hepatitis B infection. They have less chances of developing drug resistance. In women of childbearing age, tenofovir may be preferred, and entecavir is not recommended during pregnancy. Entecavir is recommended in children aged 2 to 11 years. Whom to treat? All adults, adolescents, and children with chronic hepatitis B and evidence of compensated or decompensated cirrhosis should be treated, regardless of the enzyme level, infectivity status, or DNA level. Treatment is recommended for adults with chronic hepatitis B who do not have evidence of cirrhosis but aged more than 30 years, have persistently abnormal levels of enzymes, and evidence of high replication of DNA. It means chronic hepatitis B patient, if having cirrhosis, whether compensated or decompensated, they should be treated by antiviral drugs of hepatitis B. But if the patient of chronic hepatitis B is not having evidence of cirrhosis, they can be treated if they are having age more than 30 years, have persistently abnormal levels of enzymes, have evidence of high infectivity, for example, DNA level. So if the chronic hepatitis B patient means HBs AG is positive, persistently positive, you have to see that cirrhosis is present or not. If no cirrhosis, then you see that you can defer the treatment or monitor the enzyme level, for example, ALT and HBV DNA level. But if there is cirrhosis, then you can see that if the HBV DNA level is more than 20,000 international units per ml, then you have to initiate therapy and monitor. And the therapy preferred is nucleotide analog tenofovir. So recommended drugs for treatment of chronic hepatitis B are tenofovir disoproxil fumarate, and it is a product form. It is given 300 milligrams once daily. And in those patients which cannot tolerate this drug because of renal dysfunction, compromised renal function, or other toxicities, tenofovir alafenamide fumarate is given in the dose of 25 milligram once daily. And the other drugs for chronic hepatitis B are entecavir, and they are given in the doses of 0.5 milligram once daily in the compensated liver disease, and decompensated liver disease is given the dose of 1 milligram once daily. When to stop treatment and which patient should stop treatment? If the person has developed cirrhosis, it requires lifelong treatment with these drugs. So all the patients with cirrhosis, they should not discontinue antiviral therapy because of risk of reactivation, which may potentially lead to decompensation and death. So if any patient of chronic hepatitis B has developed cirrhosis, they should not stop the treatment. So what kind of patients can discontinue treatment? So if the person or individual of chronic hepatitis B is without cirrhosis with persistent surface antigen loss after 1 year of treatment. If the person is having chronic hepatitis B without cirrhosis and there is loss of HBs antigen after the treatment of 1 year, it can discontinue the treatment. Or there is loss of envelope antigen and seroconversion to anti-HBe after completion of 1 year of treatment or 3 years of treatment, then it can discontinue the treatment. But this decision on the discontinuation should be very critical, and it should be by a team of hepatologists and other senior faculties of this department, because relapse may occur after stopping therapy with these drugs, and retreatment is recommended if there are consistent signs of reactivation. So hepatitis A is the self-limiting illness. Hepatitis B is a very serious infection. Hepatitis A is the fecal oral transmission. Hepatitis B is the blood infection. Similarly, hepatitis C also is a blood. It is transmitted via blood and other modes like hepatitis B. All the hepatitis viruses are RNA viruses, and hepatitis B is the DNA virus. So hepatitis C infection is acquired through syringes, needles, transfusion of infected blood, sexual transmission. It can also cause acute hepatitis as well as chronic hepatitis. One thing I would like to say here that hepatitis C infection, in the last 5 years, many drugs have come into the market, and they are very good. They are having very good effect on the this is called sustained viral load or response, and they have produced a dramatic response in hepatitis C infection. So they are preferred now. We will discuss later in the slides. So whom to test about hepatitis C infection? Those people who inject drugs, men who have sex with men, female sex workers, people who received blood transfusion before routine testing, people who need frequent blood transfusion such as thalassemia and dialysis patients, people living with HIV infected patients, and inmates of prisons and other closed settings. So such persons should be screened routinely for hepatitis C infection. What is it? Marker hepatitis C RNA level. Hepatitis C infection can progress to acute hepatitis C can progress to chronic hepatitis C infection, and it can cause cirrhosis as well as long-term complication is development of hepatocellular carcinoma. Actually, chronicity is seen maximum with hepatitis C infection among the viral hepatitis. Assessment of the degree of fibrosis, and this is important to diagnose or assess the cirrhosis, features of cirrhosis. Now, directly acting antiviral drugs are available that I have talking about a few minutes before. That many drugs have come in the market and they are approved for this particular hepatitis C infection, and they are approved within last 4 or 5 years. So they are now the first line treatment in many countries, and the drugs are given according to this flow chart. Person with confirmed HCV infection, it is detected by HCV RNA. Then if the patient or a person does not have cirrhosis, you have to treat them with sofosbuvir and daclatasvir for 12 weeks. If the person or patient has cirrhosis, and that is assessed by compensated cirrhosis, and that is assessed by a criteria called Child-Pugh criteria. If the A score is there, then you have to treat with sofosbuvir and valpatasvir. So these are the drug combinations to be used for confirmed hepatitis C virus infection. And this regimen is for hepatitis C naive patient. Naive patient means those patients which have not taken any treatment before. So you should assess by HCV RNA level in these patients, and you will assess the fibrosis for the assessment of cirrhosis. If there is no criteria for cirrhosis, it means patient does not have cirrhosis. You will treat by giving sofosbuvir and daclatasvir for 12 weeks. And if the patient has cirrhosis, then you will treat by giving sofosbuvir and valpatasvir for 12 weeks. Then reconfirm by RNA level, these RNA level after 12 weeks. If the HCV RNA not detected, then treatment is completed. If HCV RNA detected even after 12 weeks of the treatment, then refer to higher center for further management. So you can see in this table also that patients without cirrhosis of HCV infection, that is uncomplicated HCV infection, the regime is sofosbuvir 400 mg plus daclatasvir 60 mg, and duration of treatment is 12 weeks. Patients with cirrhosis, that is compensated cirrhosis, cirrhosis means A, Child-Pugh criteria A, you have to treat with sofosbuvir and valpatasvir for 12 weeks. And patients with B and C criteria of cirrhosis, that is decompensated cirrhosis, you will treat by giving sofosbuvir 400 mg plus valpatasvir 100 mg and ribavirin, that is given according to the dose adjustment for 12 weeks. If ribavirin cannot be given, then you will treat by sofosbuvir and valpatasvir by giving them these two drugs for 24 weeks. So treatment of hepatitis C has become a very controlled and effective by coming these drugs, by approval of these drugs. So these drugs should be followed accordingly. When to refer such patients? If the patient has developed decompensated cirrhosis, if the patient has taken some previous treatment with some other drugs, patient on chemotherapy with deranged liver enzymes, patient with impaired renal function, patient have developed hepatocellular carcinoma, pediatric patients and thalassemia patients, they should be referred to the higher center. Drug interactions are those portions in pharmacology and therapeutics that we most often neglect, and these are the important cause of either toxicity or treatment failure. So drug interactions with these drugs is very important. For example, if the patient is also taking some other drugs, and some of them are enzyme inducers or inhibitors, so there will be altered response of these drugs. Then ribavirin therapy has some contraindications, absolute and relative contraindications. For example, pregnancy or breastfeeding women, poorly controlled cardiac failure, COPD, and co-administration with didanosine, that is the antiretroviral drugs. These are the absolute contraindication for ribavirin therapy. So you have to remember that decompensated cirrhosis, you have to give sofosbuvir, valpatasvir, and ribavirin. Those patients who can tolerate ribavirin. Those who cannot tolerate ribavirin, you have to continue sofosbuvir and valpatasvir for 24 weeks. Otherwise, 12 weeks. Now, what is the management of hepatitis C virus infection? Cirrhotic and non-cirrhotic patients, those patients uh, which have taken some other treatment, means management of treatment experienced cirrhotic and non-cirrhotic patients. So depending on the genotype, actually this SCV hepatitis C virus exists in many genotypes. So depending on the genotype, the treatment has been categorized. For example, if the treatment failure regimen was peg interferon and ribavirin or sofosbuvir and ribavirin, so then you have to categorize whether the patient has cirrhosis or compensated cirrhosis, no cirrhosis or compensated cirrhosis. So if the patient is having no cirrhosis, then you will give the same regimen, that is sofosbuvir and valproatasvir for 12 weeks in the fixed dose combination. But if it has developed compensated cirrhosis, then you have to give the same sofosbuvir and valproatasvir for genotypes other than type 3. But for genotype 3, you have to add ribavirin. Similarly, for sofosbuvir and ledipasvir and other drugs, if they have developed compensated cirrhosis or no cirrhosis, in all these categories, you have to give the sofosbuvir valproatasvir treatment regimen along with ribavirin. So this therapy of hepatitis C infection, it has improved very much by introduction of this directly acting antiviral drugs, especially the sofosbuvir and valproatasvir, and these are categorized pharmacologically as polymerase inhibitors. So these are the polymerase inhibitors, and they have made important revolution in the treatment of hepatitis C infection. Now, often it is seen that persons have co-infection with HBV and HCV. So what to do in such cases? HBV and HCV infection can occur in the same patient, and if the patient is having both infection, you have to treat according to HCV infection, antiviral therapy for HCV infection. But you have to remember that during the treatment after HCV clearance, there is risk of reactivation of hepatitis B virus, and this may require treatment with anti-HBV therapy, that is the tenofovir or entecavir. Drug interactions must be checked before initiating the treatment. So if the co-infection is present, both HBV and HCV, you have to treat according to the HCV infection. But if there is emergence or reactivation of hepatitis B virus, then you have to add the treatment of hepatitis B virus infection. Then HCV infection along with MDR-TB. Concurrent treatment of HCV infection and multi-drug resistant TB, MDR-TB, is very much complicated because of drug interactions. And in fact, MDR-TB also requires a long duration of treatment. So in this, and there are many, at least 4 or 5 drugs to be taken. So there are chances of drug interactions if there are co-infection with HCV virus. So this should be kept in mind. Persons with chronic kidney disease, actually we have no clear-cut data about the safety of these drugs, especially sofosbuvir and other drugs in the patients on the renal function. So they should be, these facts should be kept in mind before prescribing. Actually, renal function test, they should be frequently or routinely prescribed for assessing the renal function. Then women of childbearing age, the drug safety is not established yet. Ribavirin is associated with fetal abnormalities. So these drugs are contraindicated in pregnant women and those with childbearing potential. And pre-treatment pregnancy should be confirmed. Hepatitis D virus is a weak virus, and infection of hepatitis D is usually seen along with hepatitis B virus. If present, it is usually seen with hepatitis B virus. So it is a weak virus. Course is transient and self-limited. If it can also progress to chronic hepatitis D, and in such cases, interferon is the treatment of choice. Hepatitis E virus is the feature, it is having features similar to hepatitis A virus. The disease is self-limiting and transmission by fecal-oral route, and it can cause severe hepatitis, particularly in pregnant women, pregnant ladies. So in chronic hepatitis E virus infection, ribavirin therapy has been tried in some studies, but not yet proved. So these guidelines are from the various textbooks of pharmacology like Goodman-Gilman, CMDT, and National Guidelines for Diagnosis and Management of Viral Hepatitis, Government of India. So in a nutshell, I would like to conclude my discussion that viral hepatitis is important. It is present globally, but the prevalence has declined very much due to immunization schedules, and we should always follow the immunization schedules, and we should cover all the immunization programs as per schedule to the children or newborns. Because once we have properly immunized our babies or children or infants, there are very less chances of having infection further in life. And immunization consist of both passive as well as active immunization in the form of immune globulins as well as vaccines. So the healthcare professionals and the medical professionals or paramedics, they are especially prone for hepatitis B infection and C infection. So they should be very careful for such infections. And we have significant improvement in our treatment because of coming of these drugs, that is the directly acting antiviral drugs, and they have produced important or significant results in the infection of hepatitis C virus. One more important thing is that prescription of any condition apart from hepatitis, you should not write over prescription. It means or polymedicines or polytherapy. It means you should know the disease, you should know the provisional diagnosis or confirmed diagnosis, you should know the proper investigations to be included for prescribing, and you should know the drug therapy or pharmacotherapy of that condition. And one important thing I want to request you, to all of you, that you should not be rigid in referring the patient. Once you are not able to treat the patient or you are not able to control the patient, you should immediately refer the patient to the heart center. Thank you. Thank you, Vinay. Thank you, Shashwat. Hello.
Thank you, sir. Yes, sorry. Thank you, sir. Thank you for wonderful presentation. It was informative for me as well as our guest. Though we have covered all aspects of disease, I would like to ask few of questions we received from our attendees.
Definitely. Most welcome.
Thank you, sir. So, sir, our first question is, how can the prescription be made more patient-friendly so that they can understand their disorder, symptoms, and also the prescribed instruction and drugs?
Very good question. So I would like to say that prescription should be first of all, it should be in clear handwriting. If it is not possible for you to write in clear handwriting, then you can give to your patient the print out of your electronic prescription. You can type the prescription, and in most of the countries, they are following the typed prescription. So if you have not good handwriting, then you have to type the prescription, and you will give the typed prescription to the patient. And it should be clearly mentioned that which drug has to be taken at bedtime or once BD, TDS. They should be explained to the patient what is the dosing schedule for how much duration the treatment has to be taken in, so that the patient, actually the compliance or adherence of the treatment or prescription. Compliance or adherence means the patient has to take the medication for a proper duration in the proper dose for that condition. Suppose a patient of hepatitis B or hepatitis C, there are chances of chronic infection, and if he or she stop the treatment by himself or herself or by some other reason, then there are chances of grave prognosis. There are chances of mortality and severe complications. So adherence of treatment is more important than the routine prescribing. So every prescriber must follow that his or her patient is adhere to the treatment. And this is the responsibility of the doctor or prescriber, that the patient should understand what he has been written. Next question, please.
Thank you, sir. So, sir, our next question is, for a suspected case of hepatitis, what minimum test can be done in rural setup or for low socio-economic group who can't afford multiple tests and expensive, so as to confirm the diagnosis in the best possible way?
Actually, I would like to say that this condition hepatitis is, if you talk about hepatitis A and hepatitis E, those are the self-limiting conditions. But for hepatitis B and C, especially hepatitis B and C, they are to be managed by higher centers, especially the tertiary healthcare system or medical colleges or district hospitals. So from the rural side, every physician or prescriber has to write at least liver function test and renal function test. If the treatment has been started, then renal function test should be assessed, and initially liver function test, that is LFT, RFT, should be written. And particularly among the LFT, the enzyme levels, that is the ALT, AST, and the bilirubin level, and the markers of hepatitis infection. They should be initially written. But once, as I have told you, that if the patient is not, you are not able to treat the patient, then you should refer to the higher center immediately. That is your responsibility.
Yes, sir. Thank you, sir. So, sir, the last question is a good one. While prescribing drug for hepatitis and in general, can the chemical name of drug be used instead of brand name?
Very good question. This is the absolute question from the pharmacology. Actually, drug have three types of names: chemical names, non-proprietary names, that is called generic name, and the brand name or the proprietary name. Various national guidelines in many countries, they say that prescription should be by generic names or the non-proprietary names to avoid the confusion. But you have asked about the chemical name. Actually, chemical name is the very complex name, and it is based on the molecular structure of the drug. So chemical name is not easy to remember or to write. It is based on the IUPAC nomenclature of the drug. So it is actually not preferred or not used, in fact not used in any type of prescription. Then comes the generic name and the brand names. So brand names are usually they are written in the prescriptions because they are easy to remember and they are very attractive names. But for example, I would like to say here one example that they can create a lot of confusion also. For example, if you want to prescribe a patient tramadol and you have written Trabest is the brand name of that drug. But unfortunately, the chemist understood that it is written Turbest. Turbest is the drug brand name for the terbinafine. So he will prescribe terbinafine instead of tramadol. Both terbinafine, they comes with the same brand name, that is Trabest and Turbest. The difference is only E or A. If you have not written clearly, the chemist or the shop, they will give the patient terbinafine or tramadol. So brand names, this is one example, and there are a lot of such examples. So brand names actually create confusion, and ideally we should write the generic or non-proprietary names in the prescription.
Thank you, sir. Now we are done with the question. Thank you so much, sir. I think most of aspect of prescription writing in hepatitis and all over have been covered. With this,
Thank
we
you
have
so much.
now come. Yes, sir.
You can continue. Thank you so much.
With this, we have now come to an end of this wonderful session. Thank you so much, sir, for taking out time for your busy schedule. Thank you so much, sir. I'm sure this session will prove to be very much beneficial for our audience. Thank you so much once again, everyone. I would also like to thank Dr. Rajneesh Raj, President IMMSN UP, Dr. Rahul Anand, Secretary IMMSN UP, and the entire certified team for being the pillar of this workshop. Thank you all for joining in.
Your entire team needs a special mention because you are working very hard. All of you are working very hard, and many thanks from myself, and congratulations to all of you. And you should continue these type of activities not only during your UG activities, your PG activities also. Once you become PG student or a medical professional, you should continue such type of activities, that we can join such type of activities and we can spread our knowledge, and we should learn at every stage of our life. Thank you.
Thank you so much, sir. So this is Abhinay Srivastav signing off for today. Please stay tuned for tomorrow's session, which will have insight on microbiology and pathology, and other proceedings by Dr. Savita Agarwal ma'am and Dr. Ravi Shankar Gupta sir. The event will be held from 12 noon to 2 p.m. See you guys there. Thank you so much. Thank you, sir.
Thank you, sir.
Thank you.